We finished all the 10 markers of cardiology. Next, we are proceeding on to discuss the 5 marker most commonly asked 5 marker questions in cardiology. What are the short essays? Let us see what are the short essays that are asked in RGHS. Hypertensive emergency management, we saw JVP, we mentioned here and there, so you can read it once. CPR, you can read. Congestive heart failure, we have discussed under 10 marker. RAS system, we discussed under 10 marker. Corpulmonale, we discussed under 10 marker. Differential diagnosis of peripheral edema, we discussed while discussing surgery topic, and also you can brush it up. It's an easy question. Acute pulmonary edema, we discussed in acute decompensated heart failure. Sick sinus syndrome, it's asked only once and it is asked as a 3-mark question. I'll mention it at last after talking about atrial fibrillation and ventricular fibrillation. Atrial fibrillation, you see, it has been asked many times as a 5 marker and one time as a 10 marker. So atrial fibrillation will be starting shortly. We have ventricular fibrillation as twice. We'll see it. Only 5 to 6 lines are there about it in the textbook. Complete heart block only once. I am not covering. Antiarrhythmic drugs you will get to know when I discuss about atrial fibrillation and ventricular fibrillation. Amiodarone in clinical practice you can mention after discussion of these two topics. Pacemaker in heart also you can mention after that. Atherosclerosis risk factor we have already seen. Coronary artery disease we have seen. Prinzmetal's angina we have seen. Angina pectoris we have seen. Chronic stable angina we have seen. Acute myocardial infarction we have seen. Unstable angina we have seen. Ventricular remodeling also we have discussed while discussing ischemic heart disease. Serum markers of MI. Serum markers of MI, you can read it. It was taught in biochemistry, so you can brush up your knowledge afterwards. Aneurysm of heart are not so important, you can skip it. Marfan syndrome as twice. I'll try to discuss it in evening session. Hypertension we have discussed. Secondary hypertension causes and investigations we have discussed. Target organ damage we have discussed. Complications of essential hypertension we have discussed. Grades of hypertensive retinopathy discussed. ARB discussed. Carvedilol we have seen. Accelerated hypertension, nothing but a malignant hypertension discussed. ACE inhibitors discussed. While discussing about hypertension and heart disease, you can take points from there and mention here. I already mentioned acute rheumatic failure and infective endocarditis are two important cardiology questions which are very, very important, which are asked as frequently as 10 markers and 5 markers. Please go through it once because I'm not covering it because it has been covered in microbiology. And then we have mitral stenosis, mitral regurgitation, and aortic rejection, which we will see. Atrial septal defect, ventricular septal defect, tetralogy of Fallot. It is a pediatric question. We'll discuss when we discuss pediatric cardiology. Hypertrophic myocardiopathy, we'll see once. Cardiomyopathy has been asked only twice. Once hypertrophic cardiomyopathy has been asked. Once as a 10 marker question, cardiomyopathy has been asked. So we'll see if we have time after this session, we can do cardiomyopathy and valvular heart disease afterwards. Cardiac tamponade is a pure surgical topic. Also, pulsus paradoxus is asked only once, so I'm not covering. So in 5 markers, I'm covering atrial fibrillation and ventricular fibrillation. In the evening session, we'll see Marfan syndrome and valvular heart disease, MS, MR, and AR, and also AS, which is as 3 marker. We'll touch upon it briefly. Now I'm starting with arrhythmia. What is arrhythmia? Arrhythmia. There is impaired heart rate or impaired electrical rhythm. What is impaired electrical rhythm? The RR interval is impaired or the PR interval is impaired. All those electrical rhythm impairment. Impaired heart rate or electrical rhythm, which leads on to impaired contraction of heart muscles, is called as arrhythmia. Arrhythmia is impaired heart rate or electrical rhythm with impaired contraction of heart muscles. What are the types of arrhythmia that we see? For ease of understanding, I have classified arrhythmia into 3 broad classifications, which is not given in textbook. Sub classifications are the ones which are mentioned. This is for ease of understanding. I have categorized it. One which is above septum, that is atrioventricular septum, below atrioventricular septum, above atrioventricular septum, and at atrioventricular septum. Above atrioventricular septum, we can see 6 sinus syndrome, which is as only once as 5 marker, and also as which is as 3 marker. You can go through it briefly. Only 5 to 6 lines are mentioned. After discussing atrial fibrillation and ventricular fibrillation, I will also mention briefly about the 6 sinus syndrome. Above septum, we have 6 sinus syndrome and atrial fibrillation. At the septum, we have AV nodes, disorders like AV blocks, complete heart block, first degree heart block, second degree heart block, not important with respect to RGHS exams. Below septum, we have ventricular tachycardia, ventricular fibrillation, and premature ventricular systole. In this, I am discussing the most commonly asked question, that is atrial fibrillation. Now, what is atrial fibrillation? Atrial fibrillation is atrial rate between 350 to 600 per minute, which leads on to ineffective contraction of atria. Atria will be like grrr. So you have seen the vibratory machine grrr. So if it vibrates so fast, it will not be able to contract adequately. So there is impaired atrial contraction due to this 350 to 600 per minute rate, which leads on to ventricular rate impairment. The ventricular rate is irregular between 100 to 140 thanks to our AV node. Because if this 350 to 600 were all transmitted to ventricle, the patient may have died instantly. The AV node is the hero. AV node is the hero, which prevents most of the impulses from atria in reaching the ventricle, thereby making atrial fibrillation as a not life-threatening condition, relatively safe condition to have. The definition of atrial fibrillation we have seen, that is the atrial rate between 350 to 600 per minute, which leads on to inadequate contraction of atria, leading on to irregular ventricular rate. And also we saw the hero, the AV node. Then we have etiopathogenesis. Also, as always, we have cardiac and non-cardiac causes of atrial fibrillation. What are the cardiac causes of atrial fibrillation? We already saw that ischemic heart disease can lead on to atrial fibrillation. Long-standing hypertension is one of the causes of atrial fibrillation. We discussed under target organ failure, target organ damage under hypertension. The mitral regurgitation, mitral stenosis, mitral prolapse will lead on to atrial fibrillation. How? I'll mention it shortly. And also dilated cardiomyopathy is one of the cause of atrial fibrillation. How? Long-standing hypertension and mitral diseases like regurgitation, mitral regurgitation, MS, and mitral valve prolapse is leading on to atrial fibrillation. Due to this causes, increased left ventricular end diastolic pressure, meaning the atrial pressure, left atrial pressure is increased. This stretching of the left atrium will cause increased excitability of the tissues inside the left atrium, which leads on to ectopic beat and atrial fibrillation. These are all the cardiac causes of atrial fibrillation. What are the non-cardiac causes of atrial fibrillation? The non-cardiac causes are thyrotoxicosis, increased T3, T4 levels, right heart, the diseases, pulmonary diseases like COPD, pulmonary embolism, and pneumonia, causing right heart failure, and secondarily leading on to atrial fibrillation due to stretching of right atrium, is one of the causes of atrial fibrillation. The pulmonary causes of atrial fibrillation are COPD, chronic obstructive pulmonary diseases, the pulmonary embolism, and pneumonia. And I'll go off track to mention that COPD, pulmonary embolism, and pneumonia causing right heart failure is called cor pulmonale, which is a 5-mark question. Okay. And also, if the patient has taken some drugs and intake of alcohol is known to precipitate atrial fibrillation, also it may be idiopathic. So, cardiac and non-cardiac causes. Under cardiac, we have ischemic heart disease, mitral diseases, and long-standing hypertension. Under non-cardiac causes, we have thyrotoxicosis, pulmonary diseases like COPD, pulmonary embolism, pneumonia, alcohol and drug intake, and idiopathic. And also, we have secondary reasons has serum electrolyte disturbance, hyper or hypokalemia, hyper or hypocalcemia, and hypomagnesemia is the causes of atrial fibrillation. So these cardiac and non-cardiac causes cause ectopic beat inside the atria. Normally, the sign SI node is only responsible for production of impulse. If any of the inside small regions inside the atrium, the region of atrium around the pulmonary veins, etc., start producing electrical impulse, it is called as ectopic beat. The production of ectopic beat will lead on to atrial fibrillation, the increased atrial rate. And also, after this ectopic beat has been produced, they will not be conducted to ventricle. They will go on circling inside. Ectopic beat produced, goes here, comes back, goes here, comes back, goes here, comes back. Like this, it causes re-entry phenomena. So the primary mechanisms causing atrial fibrillations are ectopic beat and re-entry phenomena, leading on to atrial fibrillation. By this, we have completed definition and idiopathophysiology of atrial fibrillation. Let's proceed on to clinical manifestations and management of atrial fibrillation. What are the clinical manifestations that we see in case of atrial fibrillation? What are the signs and symptoms that we see? The left atrium and right atrium is responsible for around 30%, 15 to 30% last filling of left ventricle. Sorry. Yes, left ventricle and right ventricle correspondingly. So when this doesn't contract adequately, there is reduced filling of left ventricle and right ventricle. This reduced filling of left ventricle and right ventricle in turn causes reduced ejection fraction, and reduced ejection fraction will result in reduced perfusion. Due to reduced perfusion of cerebrum, due to reduced CNS perfusion, the patient may have lightheadedness and dizziness. Due to reduced blood supply to myocardium, the patient may have anginal pain. And also due to the tupuk fastly beating heart, the patient may have palpitation. And we have one of the dreaded complication of atrial fibrillation, that is thromboembolism. See, when the atria doesn't contract adequately, it leads to stasis of blood inside the left atria. By virtue of triad, we know that stasis of blood will lead on to thrombus formation. The thrombus which is formed inside the left atria may get dislodged and cause embolic manifestations like DVT, acute limb occlusions, not DVT, sorry, acute limb occlusion, stroke, embolic stroke, the embolism blocking renal arteries, etc., etc. These embolic phenomena can be seen in case of atrial fibrillation. So these are the clinical manifestations. We have symptoms. The symptoms are ischemia related one, that is CNS and heart related, lightheadedness, dizziness, and anginal pain, palpitations, and manifestations related to thromboembolism. Let's see what are the signs that we see in case of atrial fibrillation. Are irregular pulse. Why so? During atrial fibrillation, only few impulses of atria are transmitted to ventricle. Only few, the two at irregular interval. Since only few impulses are being transmitted from atria to ventricle at irregular interval, it leads to irregular contracting left ventricle, leading on to irregular pulse with variable volume. We saw why stroke volume is impaired in case of atrial fibrillation already. So we can see irregular pulse in case of atrial fibrillation, and also on JVP there will be absence of A wave, which is obvious because if the atria is not contracting, the A wave, which is caused due to atrial contraction, will not be there. What about pulse deficit? What is pulse deficit? If one examiner is calculating the pulse of the patient and other examiner simultaneously auscultating the heart sounds, both the heart sounds and heart rate heard by auscultation and heart rate calculated by palpation should be same. If it is not matching, that is the heart rate by auscultation at the apex and heart rate by palpation of radial artery is not matching, as in case of atrial fibrillation, it is called as pulse deficit, which is one of the signs of atrial fibrillation. So we saw the signs of atrial fibrillation. Those are irregular pulse, absence of A wave on JVP, and pulse deficit. Now, what are the investigations findings in case of atrial fibrillations? In atrial fibrillation, if we do ECG, the atrial depolarization will cause P wave. So here the atrial depolarization is impaired, leading on to absence or undulating P wave. Due to this, we may have varying RR interval due to irregular contracting ventricle, leading on to irregular pulse. This increased atrial rate, obviously. And also on echo, we can see left atrial enlargement. I already mentioned these cardiac causes causing increased left atrial stretch and increased LVEDP. So we can see a left atrial enlargement on echo. If we do transesophageal echo, we can see if the patient has developed thrombus inside the left atrium, we can see the thrombus and treat adequately. And also we have other investigations like TFT, because hypo and hypothyroidism is associated with atrial fibrillation. We should do serum electrolyte examination, serum electrolyte estimation, because hypo and hyperkalemia, hypomagnesium and hypo and hypercalcemia is associated with atrial fibrillation. This is about the investigations seen in atrial fibrillation. What are the treatments that we do in case of atrial fibrillation treatment? Patients. When the patients present to you with atrial fibrillation, at that point, we'll do two things. First, we have to control the atrial rate, the ectopic tissue or the re-entry circuit which are causing atrial fibrillation. We should control it first. Control the rate. And also, the impaired rate of atria leading on to impaired ventricular rate is not acceptable. The ventricular rate is very important because it's responsible for systemic perfusion. So we have to control the ventricular rate adequately. These are the two main goals when the patient acutely presents with atrial fibrillation. How to stop the re-entry phenomena or the ectopic circuits? You can do DC shock or defibrillation, or you can do pharmacological cardioversion, that is with fecamide and amiodarone. Those are anti-arrhythmic drugs. If this pharmacological treatment cardioversion fails, please don't go on and do DC shock immediately. No, you can do electrical cardioversion only after 3 weeks of treatment with warfarin. So under acute management, We have rate control and rhythm control. Rate control and rhythm control. In cardioversion, we have DC shock and pharmacological cardioversion. Under pharmacological, we have fecamide and amiodarone. If it fails, we give warfarin for patients for 3 weeks, followed by electrical cardioversion. That is asynchronous DC shock. We have controlled the rhythm of patients. The atrial ectopic center, re-entry phenomena is controlled. Simultaneously, we'll control the ventricular rate because it's very, very important to control ventricular rate for adequate systemic perfusion. We ensure the ventricular rate to be less than 100 per minute, that is normal, by giving digoxin or calcium channel blockers like verapamil and diltiazem. We have seen under acute management, we control rate and rhythm using adequate drugs. And what about anticoagulation? Anticoagulation with heparin or warfarin is not suggested in all patients with atrial fibrillation. It's only indicated in some patients. So I have mentioned plus or minus anticoagulation here. What is the anticoagulation that we give to the patient? In which conditions we suggest anticoagulations in the patient? If the patient has mitral valve prolapse or mitral stenosis leading on to atrial fibrillation, the patient should take anticoagulants because it is the MVP and MS is itself the risk factors for developing thrombus. On top of it, the patient has atrial fibrillation, so we have to give anticoagulation. On transesophageal echo, if we see thrombi, we should give warfarin therapy for 3 weeks. If you see the thrombi, don't do DC shock immediately because you may iatrogenically induce stroke or acute limb phenomena. If you see the thrombi, give warfarin therapy for 3 weeks, then do cardioversion, either pharmacological or DC shock. Then continue warfarin therapy for another 4 weeks after cardioversion. Unsuccessful cardioversion is one of the indications of anticoagulation. We will see what it is shortly. So under acute management, we'll control the rhythm, the rate of the patient, and we give anticoagulants in some selected patients. Now, the event has been controlled, but the primary pathology is not being treated yet, so it may recur again. So how to reduce the recurrence? If at the first, when we do cardioversion, the rhythm and rate of the patient is controlled adequately, we can put the patient on oral therapy like quinidine, dronedarone more than amiodarone because it's associated with less complications. If the patient has gone successful cardioversion, we will give quinidine, dronedarone, quinidine or dronedarone to the patient. Now, you have tried all these things, but the patient has not improved, meaning the cardioversion is unsuccessful. The rate and rhythm are resistant for your treatment. Then we'll let the atrial contract like tapa 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 with reducing the risk of atrial fibrillation. We know the impairment of ventricular rate and stroke and thromboembolism are important complications of atrial fibrillation. If we can't control the atrial rate, we will manage the complications of it. That is, we control ventricular rate by giving calcium channel blockers and beta blockers. And also we can give chronic anticoagulation. That is what I meant when I told unsuccessful cardioversion as an indication for anticoagulation. By this, I am successfully completing all the things about arrhythmia. Arrhythmia definition we saw, it's an impairment in rate or electrical rhythm leading on to impaired contraction of atria or heart muscles. So, atrial fibrillation, idiopathogenesis, cardiac and non-cardiac. Cardiac causes are ischemic heart disease and mitral diseases, long-standing hypertension. And non-cardiac causes are pulmonary causes like COPD, pulmonary embolism, pneumonia, thyrotoxicosis, electrolyte imbalance, and alcohol intake. All these causes atrial fibrillation by two mechanisms, that is ectopic beat and re-entry phenomena. The clinical manifestations are symptoms: lightheadedness due to ischemia, lightheadedness and dizziness; anginal pain due to myocardial ischemia; palpitations due to tabuk of heart; and then thromboembolism. Then signs which are irregular pulse, absence of A wave and pulse deficit. After that, we saw investigations, ECG, where we see absent or undulating P wave, varying RR interval, increased atrial rate. On echo, we can see increased left atrial size and thrombus on transesophageal echo. We'll do TFT and serum electrolyte estimation. On treatment, we saw acute management, cardioversion and ventricular rate control. If unsuccessful, we can do ventricular rate control and anticoagulation. So cardioversion can be done by DC shock and pharmacological therapy. Pharmacological cardioversion by flecainide and amiodarone. If unsuccessful, please don't do immediately DC shock. Rather, first give warfarin for 3 weeks, followed by electrical cardioversion and continue of warfarin therapy for another 4 weeks. The indications of anticoagulation are MVP and MS, leading on to AFib, thrombus on transesophageal echo, and unsuccessful cardioversion is one of the indications for anticoagulation. How to prevent recurrence? If the patient has successful cardioversion, give oral quinidine or dronedarone. Or if the cardioversion is unsuccessful, control the ventricular rate by giving CCB and beta blockers. And you should give chronic anticoagulation to prevent thromboembolism, which is seen in atrial fibrillation. This is all about atrial fibrillation. So what is ventricular fibrillation? Ventricular fibrillation, I told you in textbook only 3 to 4 sentences are mentioned. You can open and see. But it's asked as a 5-mark question at once or twice, so I am covering it because it's very easy. What are the causes of ventricular fibrillation? As with atrial fibrillation, ischemic heart disease, valvular heart diseases, myocarditis. You can elaborate on this. You can write acute MI and all. All these causes lead on to ventricular fibrillation. Now, how do we detect ventricular fibrillation? Ventricular fibrillation is characterized by very rapid, irregular pulse and uncoordinated movements of ventricles with no mechanical effect. What I told is, when atria go for atrial fibrillation, it's not a big headache for us because atria is not responsible for systemic perfusion. It only pumps the blood to ventricle. That too, the last push is given by atria. 70 to 75% of filling occurs during diastole without any atrial contractions. So ineffective atrial contraction, that is atrial fibrillation, is not life-threatening. But the big boss, if the ventricle stops contracting adequately, there will be reduced systemic perfusion, reduced cerebral perfusion, which may lead on to death, imminent death of the patient. Ventricular fibrillations, it characterized by very rapid, irregular contractions of ventricle with impaired pumping action of ventricle into systemic perfusion. It leads on to impaired perfusion. The patient, what are the clinical manifestations of ventricular fibrillation? The patient will be pulseless. Why? Because there is no ventricular contractions. When there is no ventricular contraction, no pulse. And also, as I mentioned, due to reduced systemic perfusion, rapidly the patient will become unconscious. There is a cessation of respiration, cardiac arrest, and death of the patient. So on ECG, we can see bizarre or shapeless R waves. Bizarre or shapeless R waves like this. Ventricular fibrillation rarely reverses spontaneously. If the patient luckily presents to you with ventricular fibrillation, you can save the patient by giving electrical defibrillation. This is about ventricular fibrillation. Ventricular fibrillation, we saw the causes. It may be valvular heart disease, myocarditis, ischemic heart disease, and acute MI. The clinical manifestations, we saw the patient is pulseless, unconscious, and pulmonary cardiac arrest is seen, may lead on to death. ECG, we saw shapeless, bizarre R waves. The treatment is electrical defibrillation. This is about ventricular fibrillation. We quickly see the 3-mark question, that is 6 sinus syndrome. The 6 sinus syndrome. What is 6 sinus syndrome? 6 sinus syndrome is the syndrome where there is impaired generation of electrical impulse by SA node, leading on to impaired atrial rate, which causes rarely symptoms while the cardiac demand is increased. I hope you understood the definition. It's the impaired generation of impulses from SA node leading on to impaired atrial rate, which leads on to impaired perfusion on demand. The disease, a spectrum of disease that we see in 6 sinus syndrome are sinus arrhythmia, that is sinus tachycardia and sinus bradycardia, supraventricular tachycardia, and also atrioventricular block. What are the causes of 6 sinus syndrome? The causes are ischemia, secondary to coronary heart disease, ischemic heart disease, or the healed MI with fibrosis. Some drugs and autonomic disturbance can lead on to 6 sinus syndrome. Please remember, most of the patients with 6 sinus syndrome are asymptomatic. We will only pick up them on ECG. If the patient is asymptomatic, you need not treat the patient. No treatment is required, boss. If the patient is symptomatic, which is only seen in some patients, those will be syncope and palpitations. Syncope because of reduced cerebral perfusion, and palpitation because of impaired atrial rate. So, if the patient has syncope and palpitations, repeated symptomatic bradycardia, sinus bradycardia, can be treated with permanent pacemaker placement. This is about 6 sinus syndrome. The spectrum of disease that we see: sinus tachycardia and bradycardia, supraventricular tachycardia, and AV block. Causes are ischemic heart disease, the fibrosis secondary to MI, the drugs and autonomic nervous system impairment. Clinical manifestation, most of them are asymptomatic. Some symptomatic patients have symptoms like syncope and palpitations. If the patient has repeated symptomatic sinus bradycardia, we'll treat the patient by giving permanent pacemaker. This is all about arrhythmia for RGHS exam. Thank you for listening. Okay, Guru. ಇಲ್ಲಿಗೆ arrhythmia topic ಮುಗಿಯುತ್ತೆ ಗುರು. ಇನ್ನು valvular